Hi, this is Mark Struthers. Today we're going to talk about trauma patients under the influence. Many trauma emergency patients are impaired from either drugs or alcohol. These are some of the most challenging patients to deal with in an emergency medical trauma center. Emergency medical specialty is concerned with the care of patients suffering from sudden and often life-threatening illness or injury, where injured or ill patients are treated 24 hours a day. There are basically three categories of trauma patient. Category 1 would be a severe injury, and the patient will benefit from a trauma center care. Category 2 is a significant mechanism of injury, and the patient may benefit from a trauma care center. And Category 3 is a minimal potential for severe injury and should be treated at a local hospital or an emergency center. This presentation highlights working with trauma patients that are under the influence or intoxicated or drug addicted. One of the things that we need to do as soon as possible is to be able to determine if the patient is actually intoxicated or if they may have some condition that mimics intoxication. One of the first signs of a severe head injury is agitation or confusion. It can be hard to weed out if it's drugs, alcohol, or related to a head injury, or if it's related to another condition outside of the trauma or some condition that has to deal with kidney disease, metabolic disease, low sodium, etc. When we look at trauma and injuries that come through the ER, we need to understand that the injuries are a major healthcare problem, but they can also lead to other healthcare problems, including being hospitalized or surgery. Injuries are a major healthcare problem and the leading cause of death for people ages 1 to 44. Fatalities, however, are only a small part of the total injury picture. For each injury-related death, there are 19 hospitalizations for injury and another 300 injuries that require medical attention. Alcohol and drug use are directly or indirectly responsible for many of the trauma injuries seen at the emergency room. Substance abuse touches around half of U.S. families. Most people know someone or are related to someone that has a substance abuse problem. In 2022, a study was published that covered from September 2019 to July 2021, and it covered 4,243 drivers at 7 different trauma centers who were seriously injured in crashes, and it found that 54% of the drivers tested positive for alcohol and or drugs. Of this 54%, 22% of the drivers were positive for alcohol, 25% positive for marijuana, 9% positive for opioids, and 10% were positive for stimulants, and 8% were positive for sedatives. It also found that a higher proportion of motorcyclists drive while impaired compared with drivers of other types of vehicles. For example, 27% of motorcycle drivers involved in fatal crashes in 2020 were impaired by alcohol, compared with 23% of car drivers. To properly manage the alcohol-impaired patient, the emergency physician must understand several important clinical and medical legal principles. Working with trauma patients in the ER can be very chaotic, and it is even more so when these patients are under the influence of drugs or alcohol. The Drug Abuse Warning Network states that cultural sensitivity and competency are of primary importance since minority groups account for a sizable proportion of drug-related emergency room visits. Often, minority cultures have different ideas about not only drinking and alcohol and drug abuse, but on hospital and medical care. In trying to communicate with them, it is difficult at best because of their intoxicated state, but it is even more difficult because they have a different perspective. Another complication in communications is the difference between people that are under the influence of alcohol and those that are under the influence of drugs, or both. The range of impairment actually varies dramatically from very little impairment to totally intoxicated and incoherent. Whether minimally impaired or totally incoherent, we must provide the best quality care to the patient. There is a tremendous cost to people being admitted with trauma that are either under the influence of alcohol or drugs. Alcohol consumption prior to injury has been shown to lead to higher rates of infection-related complications and more diagnostic tests, which ultimately results in longer lengths of stay, extra procedures, and higher hospital costs. In a 2022 survey in the United States, it was found that motor vehicle crashes involving alcohol-impaired drivers accounted for at least 30% of all traffic-related deaths. On average, 32 people in the United States are killed every day in crashes involving an alcohol-impaired driver. This is one death every 45 minutes. Many of those killed are actually victims of the impaired driver. When examining an impaired patient, it is impossible to detect every traumatic injury that coexists with a medical problem or every type of substance that has been used or ingested in the intoxicated patient. You never know what or who will come in next. It is important to separate intoxication from medical conditions in trauma patients. At times, they appear to have the same symptoms. One of the first signs of severe head injury is agitation or confusion, which can be hard to distinguish from symptoms of intoxication. It is a sad fact that roughly half of all adult trauma patients that are seen in the emergency room will be under the influence of either alcohol or drugs. Looking at the big picture, alcohol contributes to more cases of physical violence than any other illicit substance. Many times those in the emergency room that are being seen are actually victims of abuse. This also tends to make the emergency room a primary place for secondary abuse to happen as the perpetrator comes in to finish the job, putting patients and healthcare employees at risk. Physicians are often placed in the difficult position of making rapid decisions about intoxicated patients who refuse care or are attempting to leave the emergency department against medical advice, AMA. In general, patients who present to the emergency department with a significant alteration in mental status are deemed incompetent to make medical decisions. Technically, only the legal system can declare incompetence. In the realm of medical malpractice, the standard of care is a legal term that refers to the level of competence that most doctors would have conducted themselves with in similar circumstances when treating a patient. This is where an emergency room doctor will be granted some leeway. The standard of care in an emergency room will usually not be as high a standard of care as that which would happen in a less hectic environment. To properly assess for substance use disorders in the emergency department, an evaluation paradigm that includes the following 5 components can be used. First and most important, the person that is making the evaluation must clarify their personal views about substance abuse and disorders. The evaluator must understand specific issues related to cultural norms and screening for substance use disorders and dual diagnoses. The evaluator must then develop a treatment plan that includes referrals after the patient is released. Obstacles that make conducting a proper evaluation for alcohol and substance abuse disorders are difficult. It is important that the physician provider has the capability to communicate and interact with the patient, understanding the chaotic environment and the patient's emotional and cognitive status at time of evaluation. The two main obstacles in communicating with the patient that are inherent to the patient is a state of acute emotional and cognitive instability and a low level of awareness regarding problems related to their substance abuse. When dealing with these befuddled patients, the physician must be aware of the elements of malpractice, which are, first, direct causation. Something you did resulted in the claim of the patient. Next, damages. Something you did resulted in damages being sustained by the patient. Another element of malpractice is deviation from the standard of care. In addition, there is dereliction of duty. Something you failed to do caused a problem or a loss to the patient. There's an interesting phenomenon when it comes to malpractice suits. Patients don't sue doctors that they feel are trying to help them and that they communicate well with, whereas a doctor that they do not communicate well with and have misguided feelings about how they were treated often ends up being sued. Effective communication is essential in successful assessment and resuscitating critically ill trauma patients, especially in times of high stress. The patient must understand what is being done, how it's being done, and why it's being done, so that there is no misunderstanding about the treatment at a later date. Despite a patient's objections and a common physician bias against working with intoxicated patients, they do warrant meticulous evaluation and aggressive treatment when indicated. The intoxicated patient often presents with an altered mental status, express suicidal ideation, and at times are belligerent and physically violent. And there are no federal laws designed to protect healthcare workers from any assault by a patient, and only 32 states have laws that protect healthcare workers from patient assault. Conversely, patients are protected on being restrained and being falsely imprisoned. It's a catch-22 dilemma. Another very serious problem for the intoxicated patient is the ER staff cannot negotiate with the patient in such a state, and it often delays their care. If you suspect a life or limb-threatening situation, you don't want to put off addressing that. You need to get to it immediately. After the initial assessment of the patient and it appears there is no life-threatening situation, you may want to wait for the patient to sober up some. Intoxication doesn't immediately mean the patient cannot consent to treatment. If the patient is intoxicated but still understands, the patient can consent to treatment. Just because a patient's intoxicated does not mean that they can't make decisions. When interacting with these patients, you need to consider your body language and voice tone, which may seem threatening to them in their condition. Remember, you're a caregiver, not a cop. You need to acknowledge the patient's concerns, feelings, and mental state, and be very clear about what you need and expect that patient to do while they are being treated. As a healthcare professional, you must realize that an emergency room trauma patient is never, quote-unquote, just drunk. Many have obvious or subtle signs that need to be assessed. In general, based on the biomechanics of alcohol degradation, the patient's clinical condition should begin to improve in about 3 to 6 hour time frame if there are no serious injuries. The difficulty, of course, is the patient assessment, because there are alterations in their level of consciousness, pupil responses, vital signs, and their perception of pain. Their reliability in giving you a good clinical history is probably poor, and many times they do not cooperate well. After a thorough history and physical examination, if the physician determines that there is no apparent traumatic or other injury, then a period of observation is reasonable. The emergency staff should be agreeable to observation and an observation protocol that they stick with. This would include a minimum of repeat vital signs, check the patient's mental status on occasion, and neurological checks. Because every patient is unique, there is no widely accepted time interval for physicians to reevaluate the patient's intoxication status. This should be determined on a case-by-case basis. What healthcare workers must understand is any healthcare professional who acts negligently can be held liable for medical malpractice. So what a healthcare emergency room worker should know is how to avoid additional harm to the patient, attain appropriate medical assistance and provide it quickly, recognize emergency situations, and remain calm and confident. As always, thanks for your time and attention, and we'll see you soon. This is Mark Snyder.